Well, I'm delighted to be here and delighted to be in my old stomping ground with some of my favorite people. I also want to congratulate the attendees. And again, I know that travel in the world today, it's tough, but I give you guys real props from coming and trying to learn how to do some things in a slightly better way. And this is a problem that has bedeviled me since I started doing adult deformity surgery. And just so you have an idea, I had said this on a podium about 5 years ago, and people continue to quote, but I do think it's the single biggest unsolved problem in adult deformity surgery. And if you do this, you are going to have this problem, okay? And I think that, that there are very few of us who don't have somebody that's fused from the upper cervical spine or the occiput to the pelvis due to recurrent episodes of PJK. Now, what happens is, fortunately, it happens more than it is symptomatic, but it is, all of us have had the sickening feeling of usually it's something in the most inconvenient time. It's on Christmas Eve, or it's on the night of your anniversary, where you get a call from the emergency room saying Mrs. So-and-so that you did 2 weeks ago or 2 months ago or 2 years ago is in the emergency room, and she felt this pop and she's not moving her legs. And it always is difficult. And just to show you, these are all cases of mine, okay? Just to say that maybe the reason why I do it is because I've had so many of them, and as you can see here, I've tried hooks, I've tried cement augmentation, I've tried this thing and this and that, and as I said, I think each of us probably has at least one patient somewhere in our repertoire that ends up looking like this. And if I really, really knew the true solution for this, I would tell you. But I'll give you what the current concepts are, and I think something that we've reduced our PJK rate by about 2/3, and I'll show you how and what we've done to do that. So there's really, the most common classification is that by Bawacci, and it basically says, did it fail through the disc, did it fail through the ligament, did it fail through the bone, and how severe is the PJK, and is there a slippage associated with this failure? Bob Hart and others have done some nice work. This is through the ISSG, and it shows basically the upper thoracic areas are usually a ligamentous failure, and the lower thoracic ones are usually a bony failure in most cases. So what's happening is that there are certain patient factors that have been fairly strongly associated with it. And probably the biggest and strongest one is older age. But this is probably a surrogate for two different conditions. One is poor bone quality, and the second is sarcopenia. Having poor muscle mass, muscle strength is a predisposing factor. There's also some other people. These people are also more predisposed to other conditions like Parkinson's disease or myopathies that also predispose to this condition. It's been shown that there's a high association with frailty, and again, some of this is older age, but some of this is medical deconditioning and other problems. And it's also been shown to occur, as you can see on that very big person on the slide, in people that are obese, because anything in front of the gravity line is having a tendency to pull you forward. And so this is something that we did through the ISSG, looking at frailty factors, and what they showed is that the correlation between major complications, the most common one in this group was PJK, was directly related to the severity. This has been shown that bone mineral density and lower muscularity and fatty degeneration of the muscles at the lumbosacral junction is also highly correlative with PJK. And this has intrigued my interest of some of the new techniques about, paraspinal muscle stimulation, whether somehow that could be something that's protective as we're looking at future solutions for it. There are operative factors, and it's been shown that if the bigger the correction you do, the more likely it is to occur. But also, if you don't do a big enough correction and you leave residual sagittal imbalance, that's also been shown to do it. Long fusions to the pelvis have a higher association. The type of instrumentation is something that's controversial. People have advocated for the use of hooks or for the use of offset things or the use of bands, and it's all been something that's tried. And I'll show you this a little bit later in the talk. And it's probably not as effective as some authors propose. And then people have talked about doing tension bands. So these are the things which I personally have found. I do think that that some of these are modifiable about residual sagittal malalignment. You really want to get age-adjusted alignment. You don't want to try to avoid the violation of the soft tissues at the upper end of your construct. And as I said, there's some controversy about other things. And there's other things that, you have to do enough correction to correct them. And with this, there's other factors that you're going to see that I think become important to try to avoid it. So what's happening is I think there's an increased recognition the amount of correction you need really is more than just a cookbook thing across the board. And it's been shown that, that as you get older, the amount of correction you need becomes less. So for example, you can see that that for someone greater than 75, the amount of mismatch between the pelvic incidence, the lumbar lordosis, can be much better tolerated for a value up to, this case, 22, compared in a 30-year-old. You really want to have that perfectly aligned. And what's happening is, in some work through the ISSG, it shows that those people who have an age-adjusted correction have a far lower risk of the development of PJK. And it's shown that if you were overcorrected, okay, per age, you didn't get any better clinical results and you had a far higher risk of the development of PJK. So some of the techniques that I've learned is you want to avoid overcorrection. You want to have appropriate sagittal orientation of the upper instrumented vertebrae, bending the rod into the screws rather than having a straight rod and the screws being pulled up. One of the things that you're going to see in a second from the work from the French is you want to have a physiological lumbar lordosis apex, and this depends upon the Rousselet type. So in general, if you have a very low or lower PI, so let's say less than 50, you really want the apex of your lumbar lordosis to be very, very low in the lumbar spine, usually at L4-5 or L5-S1. If you have a very high pelvic incidence, let's say 75, you can have your apex drift up to the, as high as even L2-3, and you're less likely to do it. But you also need to make sure that you curve into having increased thoracic kyphosis. So basically, this is, again, looking at the location of correction. And what it was shown, the patients that developed PJK usually had the apex of their lordosis at the L1, L2, or L3 level. There was a very, very low incidence of people who had the apex lower. And this gets back to the Dr. Rousselet and the different Rousselet types. And if you do a physiological correction by the gap analysis technique, you also markedly reduce the incidence of PJK. So what's happening is these are things that I have tried. I've tried doing soft landings with hooks. I've tried intraoperative vertebroplasty at the upper level and the level above. I've tried other different things with this. And it's just not been predictably successful, but getting appropriate orientation has been predictably successful. So what's happening is that all of us, want to try to have this problem better. This is a recent paper using hooks at the upper instrumented vertebrae site, and what it showed was that it really was not predictably preventive. And so what's happening is this is the work from the Hopkins group, which were very enthusiastic initially about prevention of PJK. But what they found was that even though in the short term they had less catastrophic failures over a 5-year period of time, about a third of their patients ended up developing PJK. So it wasn't as predictive as hoped. So one of the things which I sort of gained some interest on, and this was due to finite element analysis research and whatnot, as you're going to see, is I thought that a tether, and I first started using a mersaline tape, which is a heavy suture, polyethylene suture material through the UIV, either +1 or +2. And we did some work on that, and then we did some, again, finite element analysis with that, and basically found that by using a tether, you reduce the segmental range of motion, you reduce the interdiscal pressure, and the hope was that this would help it. So basically, this led to, as I said, initially using this polyethylene tether, which I would wrap around and tighten because I couldn't tighten enough of the knot. So I put it to a cross connector and then distracted the cross connector inferiorly, and that way I could tension that tether. And what happened was that it had some value. And this showed no tether and tether, and showed the sort of the Kaplan-Meier survival curve, showing that we reduced PJK by about 40% with the use of this tether. And again, it just shows that the use of the polyethylene tether was helpful. So then some people said, well, look at, maybe one level above isn't there. If you kind of weave it up a bit higher and you tension each of the levels and you create a transition stiffness, that would be better. And this led to us trying on a finite element analysis all of these different tether configurations. And what we saw is how much we should tether and how tight the tether should be. And what we found was that if you made the tether too tight, so over 100 newtons, it basically acted like it was part of the pedicle screw fusion construct, and you failed right above where that had stopped. If you had a tether which was around 50 newtons, it was an appropriate soft landing. So that led to sort of the development of this technique, and this is an operative neurosurgery if you want to see the whole video of it. This is one of my cases, and again, a severe sagittally imbalanced patient, and this shows, and I just kind of put it in the talk rather than having a 20-minute video, but shows the high points, and it shows that I stopped at T11, I put a hole in the base of the T9 spinous process, then I put one in T8, and then I weaved it, as you can see, back and forth through this area. And this just shows me weaving, and you can actually see how it's done. You can see on the model, and weave it back the other direction, and then putting it to tensioning towers, and then eventually tensioning this to 50 newtons. And you can see the postoperative result. And this patient didn't develop PJK. Well, the funny thing is when they went and they reviewed this, they said, well, you've done other things like try to optimize patient's health and operate bone density and whatnot, which was true, but eventually we got that accepted. And then Chris Ames did something very similar and looked at 200 patients and showed that he had a reduced rate. So basically the ISSG, this is the take-home points, looked at all of our patients. And what they found was that basically the orange is people who developed PJK requiring revision. And so what they found was that if you put some type of tethering device in, you had a lower risk kind of overall. But if you look at to the far right of the slide, the most protective thing that you can do is to get your patient ideally aligned from an age-adjusted perspective. And you can see here that this is, again, looking at a variety of different implants, and this shows the impact of alignment on it. And the bottom line is with this is if I could absolutely perfectly be assured that I could align my patients intraoperatively exactly where I wanted them, there's probably not much value for a tether. But if you can't, if you're off, a tether is protective. So if you have it perfectly aligned, a tether doesn't add much to it, doesn't change it very much. But if you're out of alignment, the tether absolutely helps. And because I don't know until I stand them up whether they're ideally aligned or not, I basically put a tether in all my patients to try to go do that. And the combination of doing things like improving bone quality with anabolic bone agents, me having patients very vigorously prehabilitate to reduce sarcopenia and improve muscle strength, to try to avoid patients which I keep on getting sent in massive quantities with things like Parkinson's disease. All of those things have reduced my PJK rate by about 80%. The tether is a small part of it. I don't want to tell you the tether is the gold standard. Alignment is what you really need to do, and if you can't quite get it aligned perfectly, then the tether adds a little bit as far as helping things. So that's the current status. It remains a big problem. The risk factors remain incompletely understood. You want to avoid overcorrecting. You want to have your apex generally lower when you're not exactly sure. You want to properly contour the rod into kyphosis at the top of it, and a tether, if you're not sure whether you've got things absolutely right, is something that can be very beneficial. So thank you.
Applause. Thank you, Chris. So this is so important. There's so many insights in there. And again, just a practical question. I'm always the professional doubter, but I don't doubt what you're doing, and I use my own form for tethering. In little old ladies who are particularly prone towards us, with whatever we could do to optimize their bone, the spinous processes in the thoracic spine are frequently pretty small and fragile. Have you noticed fractures of these spinous processes as you're trying to tether? And what is the actual tension that you create with that distractor?
So I don't actually put it, I make holes in the lamina, and I use a tenaculum. So it's actually sort of a laminar screw, and so part of the thing, and again, as a disclosure for NuVasive, I'm the designer of their tether, and what happens is the needle for that is actually made to essentially go through the hole, grab the lamina, and then out through the other hole at the base of the spinous process where the laminar bone is pretty thick. Now you got to be a little careful because I'm drilling that with an MA drill bit, and I drill through and then have the two sides come together, then do it. And if you get squirrely with passing that through, you could damage the spinal cord or have other problems with that. But to let Jens's point, I do not put that through like the higher up in the spinous process because you can have those break. At that laminar junction, the bone is actually, even in old, frail people, that bone's pretty strong, and I've not had that be a problem. So what I do is that I sort of provisionally tighten the tether, and I tighten it to about 50 newtons. And then I let it relax, and the whole thing kind of will relax down over 5 minutes. Then I'll retension it up to 50 newtons again, and then I just take that. Now, for the thoracolumbar junction, it works. And I would have thought, if you'd have asked me 5 years ago, it would have been more effective in the upper thoracic area. But I've had 3 cases now where I have had people come in, and if I've stopped at T4 and I've tethered up to T2, I've had 4 cases now where they've developed a subluxation at T1-2 above my tether. So I think that probably in the thoracic area, 50 newtons is too much tension. It's making it too rigid. Or it could be, you know, I'm trying to be really careful with my dissection down to the base and make the little hole, you know, to do that. So I'm a little frustrated because I would have thought that this would have been, because the vast majority of thoracic failures are ligamentous. I would have thought this thing would have been really curative as a ligamentous supplement device. But the 50 newtons is clearly too much. So, and then the last thing is that, you know, I've talked to them, and again, like every little tweak or change you make involves an FDA submission. But it may be that the polyethylene is a bit too stiff, and one of these suture devices, materials that has a little bit more give, maybe a better surrogate, particularly for the upper thoracic area, to do that. So I don't know, Luis, what are your thoughts on it?
Well, I have very little experience in that. I had experience in cervical TDR with excessive motion, that I use the same tethering posture in the cervical with a Mexican product that was kind of like you described, you know, more forgiven.
Yeah.
But once you really tension, it's like it's very strong. So that little experience was helpful in this particular experience, but not much than that.
Please.
Great presentation. Thank you so much.
Microphone.
Yeah.
Dr. Kazemi has to come up. He had a microphone.
Thank you. So
Come up front. So
Great
the robot cameras can capture you.
So I have two questions that have kind of completely beguiled me about this. Number one, could you comment on whether the pathway to achieving that lordosis, whether it be a physiological pathway with osteotomies across multiple levels, or a sharp correction such as an AL release and a large implant, has an impact on the PJK rate? Does it matter which way we achieve our alignment?
I think it's more important where you put that alignment. So I do think I'm not a big, you know, and so I look back, and over my years, you know, in part because, as Dr. Orlay was saying in his talk, you got an area that's had 3 previous decompressions and there's scar tissue and wide laminectomy. That can be a daunting level to do a PSO for any of us, okay? And so a lot of times what would happen is someone would have a decompression from whatever, L3 or L4 to the sacrum, and you say, okay, let's just do this PSO at L2. And those L2 ones, there were 2 problems with it. One, they had a very high incidence of PJK, and the second is the lower you go down on the spine, the better your ability to correct pelvic tilt. So what's happening is those high ones, you're still retroverting your pelvis to stay up. As you get it lower, you don't need to use the same degree of correction. So what I found that I was doing, and I think, you know, I would suspect Jens and everybody else, we started moving our PSOs lower, okay? So we started doing them at L4 or L5 or even doing sacral PSOs. But at least in my hands, and I'm not as the gifted surgeon Jens is, as I started doing that, I started having more neurological complications. You know, you do a PSO and someone develop a foot drop or something like that afterwards. So, and I think that in part was that I was pretty aggressive using the lateral body wall retractors to get around and to do stuff. And I think that retraction would seem to stretch the superior exiting root when it came around. So I've been a lot more judicious about how I use those retractors. I may show them today in my demonstration, but just make you aware that I don't use them as aggressively as I used to. And then what's happening is that's where I think many of us are either doing very aggressive T-lifts, okay, and using more, you know, lordotic cages and doing some things with aggressive T-lift, or we're moving back to A-lift. So, you know, for me, you know, when I was here at UW, we did lots and lots of A-lifts, okay, and we sort of got away from it due to, you know, anterior, abdominal wall complications and other things going on. So, ALIF was really popular, and then we sort of, at least I moved to doing more T-lifts. And T-lifts were good, but, even with me really, really, really working at it, I can get about 15 degrees of lordosis with a T-lift. And that's putting a really big T-lift device and putting it up front and taking out both facet joints and squeezing down in the back. I can get about 15 degrees, maybe sometimes 20, but it's in that range. I can get if I do a front back and take off the facet joints with a hyperlordotic ALIF. If I put a 25-degree hyperlordotic ALIF in, I can get 25 degrees, okay, with facetectomies. The reason why I don't like, as I mentioned, that's why I asked the question, I've tried 30 and 35 and 40-degree ones, and I've had nerve root problems for me, probably stretching or squishing those posterior elements. So what's happening is I do feel that as we move that lordosis correction lower, we will lower our PJK rates. And that's what I work to try to do. I try to not have, because, if you've had someone who's had 6 operations, it's hard to know what their exact Rousselet type was at the beginning, okay? Yeah. And very few of those people have ever had long cassette x-rays at the beginning. But that, Rousselet, 1s and 2s are generally people with a low pelvic incidence, and 3s and 4s are generally people with a high pelvic incidence. So for me, if I've got, a low pelvic incidence, I want to put my lordosis really low. And if I have a high pelvic incidence, then it's maybe not quite as critical. I don't know if that answered all your questions.
That's awesome. Second quick question is, does distal fixation and its failure matter with PJK? In other words, just going off our whole talk about additional fixation in the lumbosacral region and trying to really minimize SI joint failure, do you think that this has an impact above?
Well, so what I do know is if you leave a lot of residual sagittal imbalance, let's just say you fracture through your sacrum and you're forward, I think those people, they're at risk for failure then both up and down, okay? So I think that we want to get adequate enough distal fixation. And, one of the things, which I think we could have a debate, this is sort of a nuanced debate, but I still have a tendency to use iliac screws in a lot of people rather than do S2 alar iliac screws. And the reason why I do that, in my mind, is I can actually change the pelvic dynamics. So if I'm locked into my iliac screws and I cantilever down, I can actually get improvement, because the sacroiliac joint generally has about 5 degrees of motion, but I can gain 5 degrees of correction through that SI joint. Okay, now whether that screws it up or whether it damages it or whatnot. But what's happening is I found that I was getting less good correction when I was using S2 alar iliac screws compared to using 1 or 2 in each side traditional iliac screws. And for me, I don't even need fluoro or anything else to put in iliac screws. Complete no-brainer and takes 5 minutes. And if you put the head down deep under the brim, you don't have these horrible complications. If you leave it up real high, it's an issue. But I think that's something that I think is a nuance, and it's weird because it's not something that you hear described very much. So again, I've had people that have got, one of these people with Harrington rod, for example, that I'll put 4 iliac screws, I'll put stacked iliac screws, and then I will rotate their pelvis, and it's amazing sometimes the amount of correction you can get through that.
Super insights. Must move forward, but before we do that, no. One more question. We have Neil Anand on. Neil, are you live? Can you speak? Neil wanted to be here. He was a victim of the airplane fiascos today or yesterday. Neil, are you live?
I am, Jens.
So in many of your great talks, you've shown phenomenal MIS reconstructions, and they frequently stop at places where we traditionally, as deformity surgeons, would not stop: L1, T12, etc. And all of us went like, you didn't go higher, question mark, question mark, question mark. And you said, I don't know why, but it works. And you basically alluded to MIS being a thing. This is a good segue for Roger Hartle's next talk. Can you argue with Chris Shaffrey, the great Chris Shaffrey here, that this is indeed an MIS result, or what do you attribute your great clinical cases and their absence of PJK to?
Thanks, Jens. Thank you. No, I think it truly is a combination of all the above. First is indications and selection. I will go back to the selection of UIV. Our UIV is the first horizontal, neutral, normal disc. That's really important. It's neutral. Back to Professor Debussy. It's rotated neutrally. It is horizontal and off the cob, and it is, and the MRI disc is normal. That's the first thing for the UIV. So wherever that is, we take it. And you're showing there's no difference in the PJK. And Larry's shown that too, actually. It doesn't matter. We stop at 12, 11, or 10. And then there's just so much more, optimizing the osteoporosis. I love the discussion on iliac screws. I agree with Chris. I do direct, low, inline, percutaneous, minimally invasive iliac screws. I've gone from S2 AI screws for almost 7 years now. And of all the reasons outlined above in the terms of skiving, I know of 2 catastrophic skiving cases. 1 death from it skiving through the SI joint. So anyway, but we can have lots of good discussion on that. But the answer is, I think, yes. Hopefully our paper will show you. I noticed Chris did not mention our paper, so I get a chance to talk about it. So we'll bring that up in our talk, which comes later, on reducing PJK.
Chris, any thoughts? So MIS, less junctional breakage, aside from not sacrificing the junctional ligaments and all that?
So I think one of the things, which maybe they actually had it right and we had it wrong, what was shown was that the difference from some ISSG work in PJK, if you got the exact same correction from an MIS approach, you had pretty similar PJK rates. But because they were doing it from a minimal approach, they didn't get quite the correction. Their correction wasn't as good. But it turns out that probably the correction that they gave was age appropriate, and in that time that we were doing it, we were really overcorrecting people. So we overcorrected people and had a lot of PJK. Neil and his MIS cohort did not correct it, and we used to poo-poo him, oh, you guys don't do a very good job. But the fact is he probably actually age appropriately corrected him. And I do think that there is some value. I'm not dismissing the value of not disrupting the muscles and the tendons and the ligaments up at that area. I think that that does have an impact. The other thing is if you see, if you've ever been to Neil's clinic, he's got these like beautiful, 35-year-old starlets from Hollywood that are coming. I have these creaky old ladies from West Virginia with their corncob pipe, and that may also have a little bit of effect on why Neil's PJK rates are a little bit better. They're doing their Tai Chi, and their yoga instructors follow them into the hospital, and they drink all that nice, sparkly water with all the vitamins and minerals in it, and my ones, well, that or a gallon of Mountain Dew, one or the other. So as I said, I don't want to underestimate what Neil's done and Neil's contribution. I do think that is something to consider.
Great talk, great topic. Thank you, Chris, again. And great segue for